Welcome to this Ask the Expert session. My name is Paul Ridker. I direct the Center for Cardiovascular Disease Prevention at the Brigham and Women's Hospital in Boston, Massachusetts, and I'm a professor of medicine at the Harvard Medical School. Today I'm going to answer several questions from the community about inflammation and the risk for developing atherosclerotic cardiovascular disease. Our first question, which is a very common one, is really what advice would I, as a cardiologist, give to a primary care clinician about monitoring cardiovascular risk, specifically in a patient with chronic kidney disease? It's really a very important question because depending on where you live, you may not have access to a nephrologist or a cardiologist on a regular basis. And I think most primary care physicians, general internists, want to handle much as they can of their own patients. We want to recognize that patients with chronic kidney disease, first and foremost, have very high cardiovascular risk. The most likely reason for death in our patient group is going to be heart attack and stroke, not progression to renal failure. And I think what we really want to do is recognize that these patients need aggressive preventive cardiovascular care. Now, most of these patients do receive statin therapy, but remember, statins become less and less effective as the GFR declines further and further. And so inflammation is a very, very important part of this process. But I'm very respectful of my primary care colleagues and my general internal medicine colleagues. We want to collaborate with you as subspecialists, but these are your patients. I think your responsibility is to them. And of course, they know you very well. So part of this is a process of working together as a group. Next question pertains to a paper we just published in the New England Journal of Medicine, which involved the Women's Health Study. The Women's Health Study was almost 28,000 initially healthy American women who we have now followed for 30 years. And we were tracking what predicted their outcomes. To summarize a great deal of data very quickly, we found that three fundamental biomarkers: high sensitivity C-reactive protein, a measure of vascular inflammation; LDL cholesterol, so-called bad cholesterol; and Lp(a) or lipoprotein A, all predicted long-term 30-year risk. Now, the strongest of these biomarkers, interestingly enough, was actually the inflammatory biomarker, the one that's probably the least often measured. But high-sensitivity CRP was the strongest of the three. LDL cholesterol was the next strongest. And Lp(a) was quite important for the relatively small number of individuals who had high levels. But more important than how strong were these was the fact that any one of them put this young person at high risk. Combinations of them put them at even higher risk. So if you were unlucky enough to have both inflammation, hyperlipidemia, and a high Lp(a), that was the highest risk group. The other issue to recognize here is that we need to be much more aggressive, in particular for women whose heart disease remains underdiagnosed and undertreated, and not wait until our patients are in their 60s and 70s to calculate risk. These women were in their early 50s when we started this study 30 years ago. We should be measuring all three of these, in my opinion, on a universal basis to understand who's at risk, what can we do about it, and how can we be honest about what long-term risk really looks like. Another question that came up is, do I think that high-sensitivity CRP screening will become routine for patients at risk for cardiovascular disease? And as a corollary, what would need to be in place for that to happen? First of all, in many parts of the world, it's already routine. Our European guidelines for primary prevention have routine high-sensitivity CRP screening, and our own ACC-AHA guidelines call for HS-CRP screening as a tiebreaker when you're trying to figure out what is the level of someone's risk, and would you perhaps put them on statin therapy, even if their LDL cholesterol level was low. I personally think we should have universal screening for high-sensitivity CRP, just as we have universal screening for LDL cholesterol. Remember, physicians will not treat what they don't measure. If we don't even tell a patient they have a pro-inflammatory response, it's going to be very difficult to say to them also, well, if I got you to stop smoking, go to the gym, exercise regularly, eat healthier, your CRP would come down and your risk would come down, the same way we would say all that for LDL cholesterol. So I do think we have to have universal screening. I'm pretty confident our guidelines will change within the next year or two to match our European colleagues who have understood the importance of inflammation for quite some time. Many of my colleagues are measuring coronary artery calcium score as a way of finding out what's a high-risk patient and what might I do about it. So the question really is there a relationship between coronary artery calcium score and systemic inflammation? It's a very thoughtful question. What coronary artery calcium score tells us is there is disease. It's actually the strongest screening test if your sole goal is to find out which of my patients are at high risk, because, of course, what it's detecting is atherosclerotic disease. So that's a very good use of a coronary artery calcium score. On the other hand, a coronary artery calcium score does not tell us anything about what to do about the fact that the patient has atherosclerotic disease. That's where measuring these biomarkers of systemic inflammation, that's the high sensitivity CRP, LDL, and LPLA come into play. Because in addition to knowing that your patient has atherosclerotic disease, the next question, of course, is what can we do about it? And if their fundamental problem is inflammatory, well, we have targeted therapies now that can lower inflammation. If their primary problem is high cholesterol, we obviously have lipid-lowering drugs we can use very aggressively. And if their primary problem is an elevated LPLA, we have clinical trials coming the next year or two, which will help us to know whether or not lowering LPLA will lower risk. And also these biomarkers will help us to do family screening. As a general rule, if I have a patient who discovers early coronary disease or has a strong family history, I'm very likely to want to measure those biomarkers as well. So I think the relationship is a tricky one because you really need to, if you are someone who likes to use coronary calcium scoring, you really need to add the biomarkers. On the other hand, we can probably figure out who's at high risk through using general risk scores, and either way of getting there is okay. What's complex about the question beyond that is that the actual clinical correlation, the actual statistical correlation between a CAC score and inflammation is not particularly strong. Coronary artery calcium tells us there's plaque, but it tells us there's calcified plaque. And calcified plaque, of course, is stable plaque. Inflammation is telling us a high likelihood of a plaque rupturing and causing a heart attack or stroke. Of course, that's non-calcified, unstable plaque. So again, these two different ways of thinking about risk go together, and particularly in our patients with chronic kidney disease, these issues are both important and will help our patients live longer, healthier lives. Thank you for joining me today. I hope you found this Ask the Expert session about inflammation and risk of atherosclerotic cardiovascular disease helpful.